Aloha everyone, my name is Kevin Brown and the date is April 10th, 2020. For my Unit 2 case connections, I'll be presenting on cases 3 and 4. For case 3, the mother of a 5-year-old boy has reported concerns over his persistent thirst and frequent urination, which, given these symptoms and the age of the boy, falls in line with the diagnosis of type 1 diabetes, which used to be called juvenile onset diabetes. Given the results of the blood sample tests, where it is shown that the serum insulin levels of the patient for a baseline blood sample are at 0.8 microunits per liter and 6 microunits per liter, plus or minus 2 baseline control, and 1 hour after glucose load, these results come in at 5 microunits per liter for the patient and 40 microunits per liter plus or minus 11 baseline for the control, we can identify that the patient's serum insulin levels are significantly lower than where they should be. To answer the first question of the case connection, we can see that because of diabetes, the body is going to see an increased rate of resistance towards insulin, which will lead to a higher blood glucose level. To go more in depth, pancreatic beta cells, which are ultimately responsible for the synthesis of insulin and its release into the system, are rendered useless by his immune system. Consequently, alpha cells that normally produce glucagon can't effectively communicate with beta cells, and we see a decrease in insulin signaling, or hepatic insulin resistance. This will inevitably lead to an increase in glucose in the bloodstream. Based on these lab results, we can see that this patient's body is not able to take in glucose effectively when compared to a healthy individual, and there will be an abnormal accumulation of blood glucose. This leads us to the answer for the case's second question. I would predict, based on the results we are seeing, that the patient's fasted blood glucose levels would be above normal because of this excess amount of glucose. I can come to this conclusion based on the fact that his body is going to be less efficient at the utilization of and storage of glucose, leading to the buildup, which will then lead to a decreased production of insulin. These problems would arise with someone suffering from what we call hyperglycemia, which, based on his symptoms of frequent urination and increased thirst, correlate exactly with this diagnosis. The next question for our case asks us to identify 2 regulatory enzymes that are likely to be active given the current condition of the patient. From our studies in the class, we know that the ultimate goal of glycolysis, which is still occurring in the boy's body, is to break down glucose and give the body the energy it needs for essential functions. A regulatory enzyme, such as glucokinase or hexokinase, is likely to be active in this situation. Located in the liver, glucokinase and hexokinase serve an essential function. Hexokinase, which has a high affinity for glucose, can be seen in the process of phosphorylating glucose 6-phosphate into fructose 6-phosphate. Another enzyme that I would expect to see active in this case is phosphofructokinase 1. This enzyme will be ultimately responsible for the phosphorylation of fructose 6-phosphate and ATP into fructose 1,6-bisphosphate. Going on to case number 4, based on the information presented in the case and what we know about the symptoms of the patient, I can conclude that the correct diagnosis for the patient is C, glycogen storage disease. This disease, otherwise known as von Gert disease, is a hereditary disorder that shows itself because of a deficiency in the enzyme glucose 6-phosphatase. Dysfunction of this enzyme in liver glycogen degradation is where the cleavage of glucose 6-phosphate is converted into free glucose. When we exhibit a deficiency of glucose 6-phosphatase, we ultimately see a slim or non-existent production of glucose. This is called hypoglycemia, and this could result in cerebral damage and compromised development in the patient. Since the patient is exhibiting jittery spells hours after breastfeeding, it is consistent with our findings. And the patient's age of 2 months also falls in the category of seeing these repercussions of the disease. These episodes typically appear during a period of fasting in between periods of nourishment. When we look at the administration of epinephrine, we can see a lot of clues into what is happening or what isn't happening. Epinephrine is a crucial hormone for glycogen dissociation. When it is given to the patient, it should ideally catalyze this breakup of glycogen into free glucose, but this was not the case. Instead, we saw an increase in blood lactate. It seems as though this administration of epinephrine led to more lactic acidosis. Epinephrine is responsible for the activation of glycogenolysis and gluconeogenesis, but we don't see this conversion of glycogen to glucose, so the pathway is not functioning well in regards to glycogenolysis. However, in gluconeogenesis, this lactate is used to carry amino acids, and both can be used as substrates in gluconeogenesis. We would expect to see the body's response in this fashion by epinephrine. We can rule out answer A because the mother has stated that the patient has only been fed breast milk since birth. Hereditary fructose intolerance could not be correct because there is no fructose coming from breast milk. It contains lactose from glucose and galactose. We can also rule out answer B because with galactosemia, the patient would have started to exhibit these set of symptoms shortly after birth. And this was not the case because 2 months have already passed. Common symptoms associated with galactosemia include difficulty with feeding, jaundice or yellowing of the skin, a poor ability to gain weight, and vomiting. We don't see any of these symptoms being exhibited in our patient. We can also rule out answer D, glucose 6-phosphate dehydrogenase deficiency as well. This genetic disorder appears to be occurring almost exclusively in males and is quite uncommon in females. This condition has to deal with the breakdown of red blood cells when exposure to certain drugs or infection is evident. This deficiency happens when someone does not have sufficient glucose 6-phosphate dehydrogenase, which is crucial to the functionality of red blood cells in the body. This seems unrelated to the case we are currently investigating. This concludes my Unit 2 case connections. Thank you everybody for watching.